So for this lecture of Unit 6, we're going to talk about muscular dystrophy. So you can't talk about muscular dystrophy without first talking about the protein dystrophin, which is found in muscle cells. And there's a gene that codes for dystrophin, which is actually the longest protein-coding human gene. So that means of all the genes in the human genome that code for proteins, it has the longest sequence, which as a result of that, it has an increased chance of spontaneous mutations. So the function of the dystrophin protein is to anchor muscle fibers, primarily in skeletal and cardiac muscle. So striated muscle, because remember, smooth muscle is not striated. And so if you look at this diagram here, you have the muscle filament here, which are shown here. And these are composed of thick filaments, which are made of myosin. And then you have thin filaments, which are composed of actin. And these slide on top of each other to carry out muscular contraction. So what dystrophin does, as you can see here, is it helps anchor the cytoskeleton and these muscle filaments to these transmembrane proteins known as alpha and beta dystroglycan. And so you can see that here and here. And so these transmembrane proteins, what they end up doing is they cross the membrane and then they connect to the extracellular matrix out here. And they're embedded, as we say here, in the sarcolemma, which is, again, a fancy name for the muscle cell membrane. And by helping to anchor to the extracellular matrix, they further provide support for the muscle cell and the muscle filaments, thus help further enabling muscle contraction. And so the dystrophin protein is critical for maintaining the structure and the stiffness of muscle fibers, and as we said, enables the cells to carry out their contractile function. So when you have an absence of dystrophin, this really compromises the integrity of muscle fiber structure. And so if you've lost this stabilizing connection to not only the cell membrane, but you've also lost this contribution from the extracellular membrane as well. And so what happens is these patients will have decreased muscle stiffness as a result of this because the muscle filaments can't contract as efficiently and as effectively. You have increased deformability of the muscle cells because this dystrophin helps maintain the actual structure of the cell and the integrity of the cell. And so you can have breakdown of the sarcolemma, so the muscle cell membrane. And what happens is by breaking down of the membrane, you can have calcium enter the cell. And calcium actually can trigger apoptosis. And so that can result in cell death or death of the muscle cells. And so overall, by losing dystrophin, you really diminish the stability and the efficiency of muscle contraction. So the most notable muscular dystrophy is Duchenne muscular dystrophy, and this is due to either a frame shift or a nonsense mutation in the dystrophin gene. If you remember, we talked about the different types of mutations in Unit 1, but just to refresh your memory, so a frame shift is when you either insert or delete a nucleotide from a gene sequence. So if you have A, T, C, G, A, T, and I'm just making this up as I go. And let's say you inserted a guanine here. So that's going to throw off this whole sequence. It's going to shift it down one. And so that could potentially change a lot of the codons downstream from this insertion. And so that could change the amino acids and change the protein sequence, the protein structure and function. And so what you can have also is you can introduce a stop codon earlier on in the sequence. So then you can really have early termination and have a severely truncated and dysfunctional protein. The other thing is nonsense mutations. If that occurred, it's when you change a coding codon to a stop codon. So you also have early termination of translation as well. And so you have a severely truncated protein and often dysfunctional protein. The inheritance is X-linked recessive. And then as far as the mechanism of the disease is obviously this is going to produce an absent or truncated dystrophin protein. And so you're going to be missing this here. You're not only going to be missing this connection and stabilization to the muscle cell membrane, but remember also from the extracellular matrix as well. And so what you're going to have is significant instability of the sarcolemma or the muscle cell membrane and the muscle cell cytoskeleton. And so what happens is the cell becomes deformed and the membrane breaks down, and then you have calcium enter into the cell. Calcium enters in and it's going to trigger a number of signaling cascades, which will eventually result in oxidative stress. and this will trigger breakdown of the muscle cells and then progressive degeneration of type 1 and type 2 fibers. So clinically, one thing you really want to pay attention to with all of these muscular dystrophies is the age of onset, because that can be one thing that will help you distinguish these, because there's going to definitely be some overlap as far as some of the clinical features. So since Duchenne is a result of a frame shift or a nonsense mutation, you're obviously going to have a severely dysfunctional or absent dystrophin protein. So you're going to see these symptoms manifest very early on in life. So typically around 5 years of age, early childhood. And what you're going to see is progressive weakness, especially in the muscles of the pelvic girdle and the proximal lower extremities. So muscles that are really responsible for moving the hips, especially hip flexion. And then as a result of that, patients are going to really complain of difficulty standing up. The way that often is phrased in a question stem is the patient had difficulty getting up from a chair or a bench or a sofa or something like that, or they had trouble climbing stairs, or both. Something that's interesting that you'll see with this is you're going to see what's called pseudo-hypertrophy of the calf muscles. And what causes that is the muscle cells have degenerated, but you still see enlargement. So the actual volume of the calf muscles is enlarged or larger, but it's not because you're increasing the muscle cells. And in fact, quite the opposite. You have degeneration of muscle cells. What happens is you have fatty tissue that's replaced this muscle tissue. So let's come down here and draw a simple diagram to illustrate this. So this will be a cross-section of a muscle, and then you're going to have these muscle fibers within the muscle like this. And then what's going to happen is you're going to have degeneration of these muscle fibers. And so what you're going to see is, shrinkage of these muscle fibers. And so you're going to have all this empty space in here, as you can see. And so what's going to happen is you're actually going to have fat come in and fill that empty space. And so fat's going to take up a lot of space. And so what's going to happen is you're going to see enlargement of the muscle, but still, the same size as far as the muscle fibers go. They're going to still be smaller and degenerated. And so it's as we say, a pseudo hypertrophy, because it's enlarged, but it's not due to increased size of the muscle cells themselves. The other thing patients will present with is a waddling gait. And then patients will use what's called a Gower maneuver to stand up, because since they have such weak lower extremity muscles, they'll use their upper extremities, their upper body, to help lift themselves up. And you often can see this mentioned in a question stem, so definitely be on the lookout for it. So as far as complications or associated symptoms, definitely can see scoliosis. This is likely to believe to be due to neuromuscular scoliosis. Because remember, there's congenital scoliosis where patients just inherit, deformity of the spine. This is more likely due to the weakness in the back muscles themselves. You're going to see muscle contractures, fatigue, obviously, because they're going to have loss of muscle tissue. They can often become wheelchair bound. And there's a central nervous system component for this disease, and it's not really well understood. Dystrophin's really well understood in muscle tissue, but the central nervous system component of this disease is not well understood. But clinically, what you'll see is these patients will present with neuropsychiatric impairments, such as ADHD, learning disabilities, cognitive deficits. So often these children have difficulty in school. You'll also see respiratory problems, and this is because, remember, the diaphragm is a skeletal muscle, and then also a lot of the intercostal muscles help contribute to breathing. And so if those muscles are weak as well, you're going to have difficulty breathing. Remember, cardiac muscle is striated and contains dystrophin, so the cardiac muscle will also be affected by this disease. So patients will have cardiac arrhythmias and then also develop dilated cardiomyopathy, which is actually the most common cause of death. So as far as diagnosing these patients, obviously you're going to have a young child come in. They're going to have that proximal leg weakness. They're going to have muscular weakness in general. They may have some of these other features as well. And then as far as the labs go, what you'll do is you'll test for serum levels of creatine kinase. And so you'll see elevation of that. Now, creatine kinase, or CK, is found in particularly high concentrations in the muscle cells. And so usually you don't see very elevated levels of this in the serum normally. But the problem is if you're having breakdown of the cell membrane and eventually cell death, what's going to happen is the contents of the cells are going to leak out of the cells. So you're going to see increased levels of creatine kinase because it's leaking out of all of these degenerated and dying off muscle cells. So if you see that obviously furthers your suspicion of Duchenne muscular dystrophy. Another thing that's commonly done is electromyography, or EMG, which is a nerve test. where they measure the conduction and electrical activity through the nerves. And what that'll show is it'll show that the pelvic and lower extremity weakness is due to muscular destruction and not nerve or spinal cord pathology. Because if it was a nerve problem, you would see decreased conductivity through the nerves. And so what really will confirm the diagnosis, and this can often be a test question, is a muscle biopsy. And so you stick a needle in the patient's muscle, typically in the leg, and what it'll show under histopathology analysis is significant muscular atrophy, myonecrosis, fibrosis, and then that fat infiltration we were talking about that causes that pseudohypertrophy. And then what give you the definitive diagnosis is genetic testing. So Becker muscular dystrophy has a lot of overlap with Duchenne muscular dystrophy. You could almost think of it as a milder form of Duchenne muscular dystrophy. And a lot of that has to do to all the way at the genetic level, where the main cause of Becker muscular dystrophy is actually a point mutation in the dystrophin gene. And so a point mutation is just where you change one nucleotide in the sequence, versus in Duchenne where you have a full frame shift, or you change from a coding codon to a stop codon, you have early truncation. And so what this really results is in just decreased levels of dystrophin, versus where you have complete absence in Duchenne. And so as a result of that, as we'll talk about on the next slide, the clinical progression is a little bit slower in Becker muscular dystrophy, and the symptoms can be a little bit less severe. The inheritance is still the same. It's X-linked recessive, and then a lot of the disease mechanism is the same. So you're going to have reduced levels of the dystrophin protein. So you're still going to have significant instability of the muscle cell and the muscle cell cytoskeleton. You're still going to have that breakdown of the muscle cell membrane, because you're still going to have reduced levels of dystrophin. And so you're going to have breakdown of that sarcolemma, and you can have calcium come in, trigger signaling cascades, increase oxidative stress, and so you're going to have breakdown of muscle cells as well. It's just going to happen at a later stage in life, and it's going to be at a slower rate. That's the main difference. So like I said earlier, the age of onset is critical to pay attention to when you're trying to distinguish these, because there's a lot of overlap in the clinical features, especially between Becker and Duchenne. And so Becker, like we said, it develops later in life because it's less severe of a genetic mutation. And so it develops later than Duchenne at around the ages of 10 to 20. So in adolescence, so teenage years, high school years. And you'll still see the same type of symptoms though. Progressive weakness, especially in the muscles of the pelvic girdle and the proximal lower extremities, those hip flexors. So same kind of complaints. They're going to have difficulty standing up, difficulty getting up from a chair, difficulty climbing stairs. They're still going to have that pseudohypertrophy of the calf muscles because they're going to still have muscle breakdown in the calf muscles, and then that fat infiltration. They'll have waddling gait, and then also these patients will use the Gower maneuver to stand up as well. Complications also very similar, that neuromuscular scoliosis, muscle contractures, muscle fatigue. These patients can become wheelchair bound just at a much later age. These patients also will have the neuropsychiatric impairments you see in Duchenne, so potentially ADHD, learning difficulties, problems in school. They can have respiratory problems, again, due to diaphragm being a skeletal muscle and the intercostal muscles being skeletal muscle. And they also can develop cardiac arrhythmias. The prognosis for these patients is a little bit better. It's a little more variable than Duchenne. These patients can live, whereas with Duchenne, usually patients have a life expectancy of about their 20s or maybe early 30s, best case scenario. Becker, it's much more variable depending on the severity of the disease. Diagnosis, very similar to Duchenne. You can see elevation of serum creatinine kinase, again, because you're still having breakdown of muscle cells. You confirm it with a muscle biopsy, and then the most definitive way to diagnose it is genetic testing. So the third and final disease we'll talk about in this lecture is myotonic dystrophy type 1. And you may recall we made mention of this back in Unit 5 when we talked about trinucleotide repeat disorders, because this is an example of a disease caused by a trinucleotide repeat, specifically a CTG trinucleotide repeat within the DMPK gene, which stands for dysfunctional myotonic dystrophy protein kinase DMPK, which codes for myotonic dystrophy protein kinase protein. And if you recall, trinucleotide repeats are when you have a 3-base sequence that gets repeated several times within the gene sequence. And this can have really devastating effects because it throws off the entire reading frame. And so you can have severely dysfunctional proteins, truncated proteins, reduced level of a protein, or even complete absence of a protein. So it can have very severe effects. The exact function of myotonic dystrophy protein kinase is not really well understood. What is understood is that it's very important for all muscular function. So cardiac muscle, skeletal muscle, and even smooth muscle. The inheritance is autosomal dominant, which makes it unique compared to Duchenne and Becker muscular dystrophies. And as far as the disease mechanism, it's not fully understood, but what is known is that you see abnormal expression of myotonin protein kinase. That results in the breakdown of muscle structure and function, which then causes atrophy of type 1 muscle fibers and muscle wasting. So clinically, this is a little more unique compared to Duchenne and Becker's. The age of onset, I guess, could be a little bit similar to Becker's. It's a little bit later in life, has a little bit wider range. It's between 12 and 30 years, so adolescence, early adulthood. And a very characteristic feature of this disorder is myotonia, especially in the hands. And the way that manifests typically is difficulty in loosening a grip after a handshake or inability to release a doorknob. So what happens is they go in for a handshake or they grab a doorknob, they contract their hand muscles, and they're not able to relax those muscles. And so that's what these patients will complain of. You can very often see these described in question stems, so you definitely want to pay attention to that and can really tip you off to this disease. You'll see muscle wasting as well, facial weakness, a little more unique compared to the other two. Also see dysphagia, which is difficulty swallowing. Complications, also a little more unique compared to the previous two diseases. You'll see testicular atrophy in males, so you have infertility, frontal balding, cataracts, cardiac arrhythmias, and then often the cause of death in these patients is from respiratory or heart failure. As far as diagnostics, you diagnose these patients either through genetic and/or molecular testing. Lastly, here we have a summary table here. This is not in your book. We added this in. You may want to just jot this down in the margin or on a free page. It really just helps you distinguish these disorders because there's a lot of overlap, but there's some key unique features that can really help you distinguish them. So Duchenne and Becker are very similar. Major differences here are the types of mutations. So Duchenne is a much more serious mutation. It's either a frame shift or a nonsense in the dystrophin gene, versus Becker is just a point mutation in the dystrophin gene. They're both X-linked recessive. Age of onset, very different as you can see here. Duchenne is much earlier because it's a much more severe mutation. Becker, it's not as severe of a mutation, so it appears later in life. Clinical features, very, very similar, a lot of overlap here. As far as myotonic dystrophy type 1, very different mutation, CTG trinucleotide repeat within the DMPK gene. So different type of genetic mechanism, different gene, different inheritance as well, autosomal dominant, later onset, so 12 to 30 years, and then a little more unique clinical features, myotonia of the hands, facial weakness, and then dysphagia. All right, so that wraps up our discussion of muscular dystrophies. Thank you for watching this sample lecture from our online biochemistry video course. You can access the entire video course and the corresponding outline format textbook on our website using the link in the description below.